Thank you, Dr. Makhani. We're going to change gears a little bit and talk now about how we manage some of the potential complications or how we deal with patients that have TAVRs in place and significant coronary artery disease. Dr. Catalin Toma, our expert coronary interventionalist, is going to talk to us about percutaneous coronary interventions with TAVR. He's going to tell us tips and tricks. Thank you, Catalin.
Thanks for having me. So no complications here, it's all good. So when we think about coronary artery disease and TAVR, we think about sort of two aspects, the coronary artery disease pre-TAVR and post-TAVR. So pre-TAVR, the important thing that we need to address is whether we should treat coronary artery disease with revascularization. And when do we do that? And this has been an evolving field. When we started doing TAVR, we used to stent everybody pre-TAVR. Now we moved to a completely different approach. This is a case that we did a while back. You see a patient with a very tight ostial RCA lesion. There's some moderate mid-LAD disease as well. So is this a patient that would need treated with revascularization pre-TAVR? If you're looking at the incidence of coronary artery disease, as you would expect, is very high in this patient population. These are old patients. They all have coronary artery disease. We detect a lot of this with coronary CTA. And it's a predictor of short and long-term mortality, but the question is treating the disease, would that impact anything? And we actually do have some randomized clinical data in this space, the activation trial, which addressed specifically this question. This is an European trial looking at PCI before TAVR in patients with mostly single-vessel disease, stable disease. And as you can see in panel A, there is complete overlap of the curves. In fact, this trial was terminated earlier. No difference in events, but there is a difference in the bleeding rate, which is high in the patients who underwent PCI, as you'd expect, because of the dual antiplatelet therapy. If you're looking at all the data combined, and by all the data I mean mostly observational studies and the randomized control trial that we talked about, you'll see that the curves overlap perfectly. There is no evidence currently that a routine PCI pre-TAVR is of any clinical benefit. Now, having said that, this is a paper that just came out in Neurointervention that looks in detail at this aspect of coronary artery disease and TAVR before and after. It's a very, very good read, and that summarizes the current evidence. It's a little more nuanced than that, right? So we individualize treatment in patients pre-TAVR. So if you have somebody who has proximal disease, like our patients, critical stenosis, more than 90%, not the 70% that's maybe IFR positive, if they have unstable presentation, a younger age, LV dysfunction due to CAD, although this is probably taboo now, or plan for what is called now high frame TAVR, as opposed to patients in which medical management is favored, patients with high risk of bleeding, mid-vessel, branch disease, old age, and planned for low frame TAVR. And I'll show you what that is. So this is back to our patient. We did, I think we might have shockwave this patient, and we got a good result. So how about coronary artery disease post-TAVR? So this becomes more of an issue of how do you do this, and what are the technical challenges here, right? If you're looking at, there are a number of studies looking at coronary access post-TAVR. As you can imagine, it's a little challenging. This is a study looking, a Canadian study looking at the STEMI patients who had a TAVR before, and as you can see, the door-to-balloon time is longer. There's a four-fold higher PCI failure in these cases, and the mortality is high. But the important thing is the incidence of STEMI in patients post-TAVR is very low, and this is substantiated by more recent data showing that the need for PCI post-TAVR in the patient population that we currently treat is relatively low. If you're looking at why does this happen, this is the ReAccess trial looking at patients who underwent PCI or coronary angiography post-TAVR. You can see the predictors for failure to access the coronaries, as you'd expect, are the high frame valves, such as the evolute valve, high implant of the valve, and misalignment of the coronary, of the commissures with the coronary arteries. There are multiple mechanisms that can make coronary access challenging, especially in these high frame valves. You have effaced sinuses, you have bulky leaflets that can get in front of the ostia of the coronaries, especially if the coronaries are low. And some of the mechanical issues related to the valve, you can have cell and ostium misalignment, so it's not necessarily commissural alignment, but there is the metal part of the valve sits right in front of the coronary, or you can have commissural misalignment, where the commissure of the valve, of the new valve, sits right in front of the coronary. And of course, there are different types of valves. Some of them have easier coronary access, and these are the low frame players, the Sapien and Accurate Neo. The higher frame players, such as Portico and particularly Evolute with a low frame, with a low small cell size, are somewhat more challenging. So how do you do this? Every interventional cardiologist will come across this in the middle of the night sometimes, and you have to know how to deal with this. This is something important for our fellows as well. With this high frame valves, such as the Evolute valve, what you want to do is prefer femoral access for these cases. You want to make sure that you position yourself in an angle that shows you the ostium of the coronary of interest very well. And this is usually an eleo-cranial angle. And you want to start with the pigtail. So the whole concept here is to try to stay inside the frame and get coaxial with the coronary artery and not get outside or not get tangled with the outside of the frame. Catheter selection, the simple rule of thumb is go 0.5 smaller than what you would use for your regular approach. You want to get as perpendicular on the frame as possible. And in order to achieve that, you want to exchange the pigtail that allow you to get inside the frame for your guide catheter and advance the catheter to the frame waist and use the J-wire. This is a trick that we've been using a lot more, the back end of the J-wire, to change the curvature of the catheter so that it allows you to get to where you need to go. Now, sometimes this doesn't happen. It's very hard to get right at the ostium or even in the zip code of the ostium. So sometimes you have to wire these vessels from outside, do an airmail approach, basically. You have to have liberal use of guide extensions to get you to the coronary. And after the PCI, it's important to be very careful when you remove the gear not to damage the frame and even dislodge the valve, which doesn't happen that often. So this is a case, a patient that we treated with a TAVR several years prior. As you can see, this is an Evolute prosthesis, comes back with angina, has some ostial RCA disease, significant LAD disease, and a CTO of the circumflex. Couldn't resist to throw that in there. So the LAD was positive, and we ended up fixing this through the Evolute frame. As you can see, the guide is sitting way outside. You appreciate in that middle panel how angulated you are relative to the ostium of the left main. So we're not close to we're working remotely here. And we can still get, with the aid of guide extensions, we can still get a very nice result. The buzzword in the TAVR world now, as far as coronary, the coronary aspect of things goes, is this commissural alignment concept. We talked a little bit, I mentioned this a little bit. The idea here is to try to avoid having the commissures of the new valve sitting right in front of the coronaries. There's several benefits to this, not only related to coronary access, but there's all these theories about improved sealing and decreased leaflet stress and suitability for basilica with subsequent TAVR. The current platforms, you can achieve this in some cases. It's not an easy thing to do, and it's not very reliable at this point. So the manufacturers now are focusing on ways of improving their platforms to achieve this. The current platforms are not geared for, they're not constructed to have torque. They're constructed to have longitudinal strength for delivery. So this is a work in progress, but it's going to be very, very interesting how this will evolve, especially when we're looking at younger patients that may need coronary work in the future. So I'm going to end up with this. I mean, if you think cathing through a single prosthesis is fun, wait until you have to do through two of them in the middle of the night. So that's a whole other topic. So thank you very much.